Intraoperative care. The intraoperative period begins when the client is transferred to the operating table. Then anesthetic agents are going to be used to completely or partially alter sensation with or without the loss of consciousness so that the surgical procedure can be done painlessly and safely. Different types of anesthesia include a general anesthesia. With this, the client has a total loss of sensation, reflexes, and consciousness. There are 4 stages of general anesthesia. We have induction, where the medication is administered with IV or inhalation and produces that unconsciousness. Excitement, which is uninhibited movements or vocalizations. The surgical anesthesia would be that appropriate level of anesthesia for the procedure, and medullary depression would include too much anesthesia. In some cases with general anesthesia, an endotracheal tube may be required for respirations during anesthesia. General anesthesia does require close monitoring of the client's status. Anesthesia would be withdrawn at the end of the procedure. With regional anesthesia, we have a loss of sensation and decreased mobility to specific anesthetized areas with the use of a local anesthetic or some other medication. There is a risk for injury and burns due to the lack of sensation. And even with regional anesthesia, some of these clients do require a sedative to help promote relaxation, but it doesn't actually put them to sleep, so to speak. It does include spinal and epidural anesthesia, and complications can include spinal headache. Well, how do we prevent a spinal headache? We keep the client lying flat. If we elevate their head, then the headache increases. So how do we treat it? Well, we can do what we call a blood patch, where the anesthesiologist will draw blood from the client's arm, and then they will inject it in the same site that the regional anesthesia was injected. And hopefully this will seal over and clot over the hole where the cerebrospinal fluid may be leaking and causing the spinal headache. The other type of anesthesia is what we call procedural sedation. This is also called conscious sedation, in which the client is free of pain, fear, and anxiety, and they're able to tolerate the procedure. Nurses have to be aware of the side effects and that these sedatives can cause respiratory depression. Then at the end of the procedure, we administer antagonists to reverse the effects. If the medication was an opioid, we administer naloxone. If it was a barbiturate that was administered, we can give flumazenil. Again, these clients require close monitoring of their status. Now, with a regional or procedural sedation, these clients usually remain in control of their airway, and it does not affect their swallowing or gag reflex. But still, we tend to administer foods and or fluids slowly after the procedure to help make sure that there are no issues. With gerontological considerations, in other words, the older adult, be aware that anesthesia, narcotics, and barbiturates can cause confusion, disorientation, or other physiological alterations in that population. The surgical team has specific roles to play in order to streamline the procedures. The anesthesiologist or the nurse anesthetist The anesthesiologist is the physician that specializes in anesthesia, whereas an anesthetist is a physician without an anesthesia specialty, or a registered nurse who's certified in anesthesia and works under the supervision of a physician. This person is going to assess the client prior to surgery, may order preoperative medications such as an anti-anxiety medication, will explain the anesthesia procedure, the risks and potential complications to the client from the anesthesia. They will administer the anesthesia, and during the procedure, this is the person sitting at the client's head that monitors the client during the surgery, and then they will also follow the client temporarily after the surgery until the anesthesia is no longer an issue. Excuse me. The surgeon heads up the surgical team, and just FYI, the anesthesiologist, anesthetist is not a member of the sterile team. So the surgeon heads up the surgical team, and they determine the procedure to be performed, obtains the client's consent. Now, this is usually just the verbal consent because the nurse usually gets the written consent. They perform the procedure, and then they follow the client after the procedure. Surgical assistants. We may have a first assistant who assists in the procedure and may assist with pre- and postoperative care. This can be a physician, a resident, or certified registered nurse. A second assistant and third assistant may be used to assist the surgeon and the first assistant. And this might be an RN or LPN or surgical technologist. All assistants are going to be sterile members of the team, as is the surgeon. The intraoperative nurses. This includes the scrub nurse or a scrub tech. This is the person that hands the instruments to the surgeon. They prepare the sutures. They receive the specimens from the surgeon. They count sponges, instruments, and needles. They are a sterile team member. And then we have the circulating nurse. The circulating nurse is kind of overseeing the entire room. This will include the health and safety of the client, and they do this by monitoring the surgical team. They don't monitor the client, they monitor the team. They assess the client for injury with interventions as necessary. They're going to help position the client on the table. Preoperatively, they will help clean the client up. Postoperatively, put dressings on, and then help take the client to the to the recovery room with the anesthesiologist. During the procedure, they may obtain and open wrapped sterile equipment before and during surgery. So let's say all of the surgical materials and instruments are laid out, but the surgeon all of a sudden decides, well, I really need this piece of equipment. Please go get it. Or I want to put a nasogastric tube down, so please go get that. And the circulating nurse is the one who will do that. They are not a sterile team member. So they just open it up and toss it onto the sterile tray, and the surgical or the scrub tech or scrub nurse will retrieve it from the table. They are going to help keep records. Again, this is not going to be vital signs. They do not do the vital signs during the procedure. They're going to assist in counting the sponges, the instruments, and needles to make sure nothing has been inadvertently left inside the client. They're going to adjust lighting. They can receive specimens from the scrub nurse, and they coordinate activities of anyone else who may be in the operating room. For example, sometimes we'll have radiology in there to take x-rays during the procedure, or a pacemaker's being put in and the representative from the company is in the operating room, etc. So the operating room is physically isolated from other areas of the hospital. Only authorized OR personnel or surgical clients are allowed in this area. The air will be filtered and positive pressure is maintained to help reduce infection. The temp is going to be kept below 70 degrees Fahrenheit to help decrease bacterial growth and provide comfort to the surgical team. They get really hot with the mask and the hat and the surgical gown and the gloves underneath that large OR light. Surgical attire will help decrease microbial growth. All symptoms of infection in the surgical team have to be reported so the client does not become infected. The furniture will be stainless steel for easy cleaning and disinfecting. There are 3 designated areas in the operating room environment. This includes an unrestricted zone where street clothes are allowed. This is where clients, personnel, and supplies will arrive. A semi-restricted zone, which does require surgical attire, but not masks. It does include sterile and clean storage areas, work areas for cleaning instruments, and corridors that lead to the restricted areas. And then the restricted areas include the OR and procedure room and the scrub sink areas. This does require full surgical attire. The client's safety and protection during surgery are essential, and strict protocols are followed to protect the client from infection. There is an intraoperative assessment prior to anesthesia administration. This can be done by the circulating nurse. During the procedure, the circulating nurse does not monitor the client. But prior to, the client nurse will look at the blood pressure, pulse, and respiratory rates. We'll look at the client's level of consciousness, their general physical condition, presence of any catheters and tubes, and they'll look at the client's medical record. They will then pass this information on to the anesthetist, anesthesiologist, and/or the surgeon. Complications would include infection prevention, and this includes monitoring for any breaks in the sterile technique or field and counting of sharps, sponges, and instruments. So anyone who is within a foot of the operating table must be sterile. They can also monitor for fluid volume excess or deficit. This is mostly done by the anesthesiologist who administers those IV fluids, but the circulating nurse is going to kind of help keep track of how many bags of IV fluids that has been provided to the anesthesiologist. And then the circulating nurse can also measure any urine output during the surgery when appropriate. Let's say they have an indwelling urinary catheter. They can kind of keep track of how much urine is in the bag. Complications can also include injury due to positioning Remember that skin breakdown can occur in as little as 2 hours due to interruption of blood flow to an area. That results in those pressure injuries. May also result in nerve injury, postoperative hypotension, dependent edema, and joint injury. Hypothermia is also a possibility due to the low temperature in the operating room. Cold IV fluids, inhalation of cool gases, exposure of body surfaces for the procedure, open wounds, prolonged activity, or intentional body temperature lowering for some surgical procedures. Another complication would be malignant hyperthermia. This is an inherited disorder in which a client reacts to some anesthesias. The body temperature, muscle metabolism, and heat production increase rapidly in response to stress, and again, some anesthetic agents. Symptoms include jaw muscle rigidity, a rapidly elevating temperature, elevated carbon dioxide levels, elevated potassium levels, metabolic acidosis, hypotension, an irregular heart rhythm, kidney failure, and, if left untreated, cardiac arrest. Again, gerontological considerations include an increased risk for injury with prolonged surgical positioning, and chronic conditions also increase the risk of complications. So a client undergoing surgery is at risk for injury due to sedation. To keep the client safe and free of injury, the nurse is going to position the client in an upright or semi-Fowler's position, assist the client with ambulation, and carefully monitor all activities. Observe for signs of respiratory distress. Encourage the client to take deep breaths and cough at least once an hour. And we're going to assist the client with ambulation and carefully monitor all activities. And your post-test.